I'm going to introduce our next speaker, who is Dr. Constantine Lyketsos. Dr. Lyketsos is chair and professor of psychiatry and behavioral sciences at Johns Hopkins Bayview. He's also vice chair of psychiatry at Johns Hopkins School of Medicine, where he's also the Elizabeth Plank Althouse Professor in Alzheimer's Disease Research. He directs Johns Hopkins Memory and Alzheimer's Treatment Center, is full-time attending physician at both Johns Hopkins Hospital and at Bayview Medical Center. He is the previous recipient of the Distinguished Scientist Award from the American Geriatric Society, the American Association for Geriatric Psychiatry. And he's led a number of really important clinical trials in the topic that he'll discuss today, which is treating behavioral symptoms in Alzheimer's disease. And I hope we might hear a little bit about something that he's the architect of, or one of the architects of, which is mild behavior impairment. So please join me in welcoming Dr. Lyketsos.
Good morning, everybody, or I should say good afternoon for me, because I'm still trying to stay on East Coast time. Let me start by thanking Dr. Grill and Dr. LaFurla for inviting me. And I also want to compliment all of you. After a really terribly rainy summer in Baltimore, it's nice to be here in the sunshine for once, and to compliment you all for taking time in this large number to come in and talk about this important topic on such a lovely day. So it's a real pleasure to be here. One of my colleagues who will speak later made the point that, Jeff Cummings gave the talk of the century a few minutes ago, and now you have to go up there. And I said, geez, I know there's no way I can succeed, so the pressure is off, because I can't have that ambition. So I truly think Dr. Cummings gave one of the best talks I've seen him give, and a very important talk, too. So my job is to talk about, and here's where I tease Cummings, one of the areas that I think he could have mentioned, but clearly he knew I was going to talk later and therefore didn't mention, which is the development of treatments for the behavioral symptoms of Alzheimer's disease. And I'm going to use the term neuropsychiatric symptoms, and I will abbreviate it as NPS from the beginning. So as I talk about NPS, that's what I'll be referring to. By NPS, we're really talking about the behavioral symptoms that are one of the major concerns of patients and caregivers, things like agitation, depression, poor sleep, poor eating, and so forth. Non-cognitive behavioral symptoms is what they used to be referred to. My own work in recent years has been around the construct of agitation, and so I will be spending at least about a third of my talk towards the end honing in on that. But I really want to try and stay as much as I can at high level and talk about treatment development for these symptoms, and a little bit about the pipeline, because we had almost an unforced moratorium for about 10 years until about 2011 in systematically developing new treatments. And I think we then had a paradigm shift in the field in terms of how we think about these symptoms. And since that, we now have a pipeline of very interesting both drug and non-drug therapies that I'll be talking about. So I think we all know that we're faced with a pandemic. This is not an epidemic, it's a pandemic because it's everywhere. And that we are looking at, if nothing changes, at well over 100 million people with Alzheimer's disease all over the world in the next, till about 2050. Very, very big numbers, with costs for the US by 2050 potentially on the order of $1 trillion annually. So a nice potential contributor to the deficit if we don't accomplish anything. So obviously a big issue, and yet even with the optimistic results that Dr. Cummings was showing to you today earlier about these amyloid-busting drugs, none of them have really been shown to stop the disease clinically in its tracks. Hopefully we will see that in the future, but all of the curves eventually trend downwards as things progress. Maybe that'll change. So what that means is that hopefully as these drugs come on the market over the next decade, we're really going to be increasing the number of people with dementia that we have to treat, because these drugs will slow but not stop the progression of the illness, and therefore that'll mean more people living with hopefully milder dementia or prodromal states for longer, but still requiring care in large numbers. So targeting behavioral symptoms is one of the ways through which we can improve the care of people day to day. So a brief case presentation that I think will frame the construct of agitation, but remind us of what we're talking about. This is an 81-year-old man with Alzheimer's, and he's easily and constantly been irritated with minor matters and blows up and takes it out on the family almost on a daily basis. He gets agitated when requests are made, so when someone tells him it's time to eat, he says, "I'll eat when I want to," but then he gets up and joins at the table, but he's yelling and screaming throughout the meal. And a particular example around Thanksgiving, he started accusing his daughter of taking his money, not buying her children gifts, basically stealing. When his brother tried to reassure him, he started physically threatening his brother and threatening to throw his brother out, even though he was living in his brother's house. This is a real case of a patient we've taken care of. And I think it exemplifies the changes in behavior and personality, the suspiciousness that are all too common. Well, the first description of someone with what we now call Alzheimer's disease came by Dr. Alzheimer, and the patient's name was Auguste D. And there have been a number of case studies around this patient. She first came to Dr. Alzheimer's attention because she was hospitalized in what we would now call a state psychiatric hospital for care, not because she had cognitive decline, but because she had delusions that her husband was unfaithful to her. And in fact, the initial interest that Alzheimer had was around these behavioral changes. So from the very beginning, we've appreciated that this illness has closely linked behavioral disturbances. Some of the population work that has been done in the last few decades, as you can see on the slide of the left, or the chart on the left, documents that essentially over time, everybody with Alzheimer-type dementia, with other forms of dementia, will develop one or more of these symptoms. So these are pretty universal. What that chart on the left shows is that over time they accumulate. So early in dementia, very few people have had them, but over time, more and more people get them. So by the time you follow people for half a dozen to 10 years, everybody's going to get one or more. And the most common over time are things like agitation and apathy. Those are the two most common. They sort of compete depending on the study about which is most common. But delusions occur in about a third of everybody as well. Sleep disturbances seem to occur in as many as half by the end of the advanced stages of dementia. Now, what you have on the right figure here is a sense of the course of the different kinds of symptoms in Alzheimer's disease. And the take-home message is that the course over time of the behavioral symptoms is different from the course over time of the cognitive or functional symptoms. So where it says panel A cognitive, those are what we call spaghetti plots of individual people over time, and you can see their mini mental trajectories. And what you see, the overall pattern is that they worsen. It's sort of a big glob of everyone getting worse. The second panel relates to functioning, measured something, the CDR sum of boxes that you heard about before. And again, there seems to be a universal pattern of going up, which in this case means worse functional symptomatology. The third panel shows you behavior, and what is characteristic of that is that they neither go up nor down, they come and go. So that behavioral symptoms in their natural history, for reasons that we don't understand, will come and go. Sometimes they'll be more severe, sometimes they'll have certain types of patterns, other times they will have different patterns. So one would call these unstable at one level, but also they're quite variable, which has made it very hard to develop treatments. You heard this morning about the importance of control groups when you're testing a drug or a non-drug therapy. You've got to have an untreated group. Well, if the target symptoms are ones that naturally come and go, it makes it harder to prove that a drug or a treatment is better than the natural up and down that you're seeing, and that's been a challenge for development. These are very bad, and I use a generic term, tremendously bad for patients and caregivers. All right. Nobody got it. And there are a number of ways that they are bad, with worse ADL impairment, quality of life, and so forth. You can see this on the slides when you go pull them. They're also associated with faster progression to severe dementia. So what that figure shows you is a comparison of people who have behavioral symptoms early in dementia and how fast it takes for them to go from mild dementia to severe dementia. And the red line are people who have these symptoms early on at a severity that's clinically impactful. And you can see that they move to severe dementia much faster than the blue line. The blue line are people who don't have them at any level of severity early on. They might develop them later. And the green line are people who have some symptoms but that don't seem to be clinically significant early on. So the difference in years is as much as 4 or 5 years at the median, meaning half the people who have behavioral symptoms at the beginning will go to severe dementia 5 years faster than the other half, which is a very substantial difference. We don't know that that's because they have the behavioral symptoms. It may be that having the behavioral symptoms means they just have worse brain disease, but the association is there, and it does raise the question of how could we impact course if we try and target these symptoms early on. Dr. Grill nicely introduced the idea of MBI, and so we've been looking at this for quite a while. MBI refers to mild behavioral impairment and is a parallel construct to mild cognitive impairment. The idea being that in the same way that folks might get clear changes that are mild in cognition that are indicative of an upcoming dementia, they might similarly get non-cognitive disturbances in the context of behavior that we call mild behavioral impairment. So the first stage was to show that neuropsychiatric symptoms in people with MCI are quite common. In fact, not only are they common, if you have MCI plus behavioral symptoms, you go on to dementia much faster. And if you go on and study a little syndrome, so now you don't just have behavioral symptoms, but you have them in ways that are clinically impactful, that last for periods of time, typically 4 to 6 months. In those instances, people go to dementia much faster than even with MCI. So the top right figure basically shows you that if you have only cognitive symptoms, your progression to dementia is not that fast. But if you have behavioral symptoms alone, MBI, or if you have MBI plus MCI, you go on to dementia much faster. And at one point, we wondered whether this progression was reflective of people who were getting frontotemporal dementia, not non-Alzheimer's dementia. And the answer is no. If you take those people who eventually have FTD out of the mix, you still have this effect that patients who eventually get Alzheimer-like dementia, those individuals will get there faster if they have MBI beforehand. So that's where the MBI idea came from. We have some very interesting work looking at right now, asking the question of, can we turn back the clock from everybody with dementia and look to see how many of them had behavioral symptoms before the onset of any cognitive symptoms? So we've now finished that analysis using a data set of about 2,000 people from the Alzheimer's disease centers. We all put our data together in one organization called the NAC, National Alzheimer's Coordinating Center. So what fraction of people from this study that I'll show you the results in a moment do you think had behavioral symptoms before they had cognitive symptoms? These are everybody who got dementia. Some of them went through MCI. How many of them do you think had behavioral symptoms before MCI, before dementia? Any guesses? I'm setting you up, I know. That's right, it's about half. It's quite dramatic. I won't spend much time on this figure here, but these are individual lines of people over time. The red little periods show when folks have dementia, the blue periods show when they have MCI, and the greens show when they have something that's not quite MCI that we called impaired not MCI. So they don't have dementia, they don't have MCI, but they're not normal. It's an unusual category. And anytime you have a shaded cell, it shows that in that period, individuals had behavioral symptomatology of a certain degree of severity. And as you can see, those in the gray areas on the left, which are the long periods, before any cognitive symptoms, you see a lot of hatched gray areas, and that adds up to about 50%. So for people who go from normal to MCI, the behavioral symptoms occur in 55% before MCI, same from normal to dementia. And it's actually higher for people who go from normal straight to dementia without MCI. That's about 64%. So the aggregate is 55%. So we think this is very important for a number of reasons. One is that it might help us identify the emergence of a cognitive disorder even earlier on clinical grounds. But for us, the other importance of this is that it might point to something that we're doing more and more using this construct of precision medicine, which is thinking of subtypes of dementia. So how might we consider folks who begin with behavioral symptoms before cognitive symptoms? Do they have the same brain disease? And if they have a slightly different brain disease, does that offer us an opportunity for treatment? If you take all behavioral symptoms and you look at the therapies that have been developed, you'll see in the last several decades, I wish I had Cummings' talent to give that kind of a historical talk, but if I could, you will see that the conceptual timeline has been, if it looks like a duck, we assume it's a duck. So that if you have Alzheimer's disease and you're depressed, we assume you have depression and we're going to treat you with antidepressants. If you have delusions or hallucinations, we're going to treat you with antipsychotics and so on and so forth. That approach basically is importing drugs developed for conditions of younger people, schizophrenia, major depression, and giving them drugs in the context now of a progressive brain disease that we call Alzheimer's disease. And the end result has been very, very poor. For example, antidepressants, really the ones that we have now, don't seem to work for the depressions that occur in people with Alzheimer's disease. If you do the randomized trials, you basically find minimal to no effect, no advantage. And yet these are used all the time. The only class of drugs that seems to be beneficial are what we call antipsychotics. They work probably in part because they deal with delusions and hallucinations that are pretty common in many of these folks, but also because they can slow people down motorically, because they are somewhat sedating, rather than because they have a very specific effect for whatever disease is causing their disturbance. And the antipsychotics, as many of you would know if you work in nursing home environments and certainly in other environments, these drugs have what is called a black box warning from the FDA, meaning that they've got an unusual risk in this setting. So there's an increased risk of death from these drugs if you have dementia. Now we're talking about an increased risk that goes from about 1% at background to 2 to 3%. So it's not a huge actual risk, but it is a doubling or tripling of the risk. So the drugs that we've had that are most commonly used for these folks in the United States are risky and not terribly effective. And now you might say these are behaviors. Why just treat them with drugs? What are the other ways to think about treating them? And in fact, the textbooks that you look at will say, well, before you give medicines, you do other interventions that maybe change the environment or perhaps help the caregivers or somehow else address what's going on with the patient. So the modern term coined by Dr. Helen Kales a couple of years ago for this are eco-psychosocial interventions, long word here. And they really talk about manipulations in the environment, educational or other interventions with caregivers, and straight up behavioral interventions that you might do with a patient so that you change some of the ways they're interacting with the environment. In general, these work reasonably well in the few well-controlled, well-designed clinical trials that have happened. The problem is that they really don't have uptake in what you might call the real world, and that's for many reasons. One is they're not terribly well standardized. Many different groups at different institutions have developed some of these interventions. They're almost homegrown. They do a study, they show that they work, but moving them beyond that to practice hasn't really happened. Probably the most important reason I think they haven't taken up is nobody gets paid to do them. It's very hard, for example, because most of these are best done by folks who interact with patients on a daily basis. In addition to family caregivers, other caregivers in nursing homes and other environments are the ones who are most effective in doing them, and yet there's no direct mechanism to get these people paid for doing these interventions. So that's the past. What's the future? What is it that we should do? Well, the first thing that we should do is realize that these conditions are different in their clinical presentation, the phenotype, and so that we should study the phenotype and think about how different phenotypes occur in the dementia construct. And then we should start thinking about their cause. What's causing them? Why are they happening? And how do we put the two together in ways that will get us to treatment? The first observation is that they overlap. This is a simple tabulation of 10 of the most common behavioral symptoms. And in the bottom left triangle, you're seeing those bolder numbers. That tells you how commonly two symptoms occur with each other. Don't worry about the details too much, just see the big picture. And out of 45 comparisons, in 38, the two-way co-occurrences are statistically significant, have an odds ratio of significance. And the co-occurrences really are not ones that you could intuitively appreciate. So if you get to the line on the left for agitation, you will see, interestingly enough, one of the things that it commonly co-occurs with is apathy. Well, if you have how does it make sense then to say that someone gets both agitated, which seems like an active, overactive state, but also is apathetic, which is an amotivated, couch potato type state? And one of the explanations is that they probably derive from erosion of what's called the executive control of the brain. One of the things that the brain does is it manages our behavior, but it manages both by reducing and increasing our behavior, if you want to think it in a simplistic way. So in that sense, you start thinking of what's going on in the brain that's leading to a patient who's both agitated and apathetic. And it may have something to do with brain circuits that have to do with how you manage your behavior, the executive control of the behavior as we talk about it. So as a result, from the phenomenology point of view, a large international collection of people like me have been talking about this for years and have used data-based approaches to propose 5 distinct groups of NPS: agitation, apathy, and circadian disorder, each of which have criteria except for the circadian disorder. And then what we call DSM legacy, depression and psychosis. We recognize that what we knew in the past from general psychiatry about major depression and schizophrenia has some value just because of the phenotype, but therefore we call them DSM legacy. But these conditions really are still different, even though they have similarities. The other 3 are really quite different from what we see. So how do we put this together in a causal model? This is quiz time. If you want to get your lunch in addition to the ticket, you have to tell people exactly what you saw in this figure. What this is trying to do at the way left is to link neurodegeneration with neuropsychiatric symptoms at the way right. And the model is that there are 2 pathways, a direct pathway and an indirect pathway. The direct pathway are those thick blue arrows, which says neurodegeneration damages key parts of the brain, leading to neuropsychiatric symptoms. And we're starting to think now in terms of circuits. I'll tell you a bit more about that. Alzheimer's is progressing. It hits the wrong circuit. You get a certain kind of behavior. That's hopefully a straightforward approach. But then we're also appreciating that most of the time when these behaviors first occur, there's something new going on in the environment, something atypical. The patient might have a bladder infection. They might have a new caregiver. There might be some trigger or some co-occurring event that may be causative or maybe combining with the direct pathway to lead to the occurrence of the behavior. So that's the indirect pathway. The direct pathways, you go straight, you damage the brain, you get the symptoms. And the indirect suggests that you have some vulnerability created in this patient that needs a second hit, if you will, for you to get the symptoms. That's the general approach that we're proposing more and more and that we're hoping to study. Well, what about the neurobiology? What is it about how the disease is progressing in the brain that could directly lead to the symptoms? So our group has proposed 3 overlapping models. One is that circuits that link the frontal lobes to the subcortical parts of the brain, which really control behavior, and Dr. Cummings has written a lot and studied these a lot over the years, that disruption to these circuits in some way is the issue. And there are 2 other kinds of circuits that are important, what are called cortical circuits and monoamine regulatory circuits. So skipping ahead, we propose that there may actually be things like an agitation circuit or an apathy circuit. These are not specifically made to make agitation or apathy, but it's circuits that have a particular function, for example, motivation, that relate to apathy, or circuits that have ways of assessing threat in the environment. So it turns out there are brain circuits that are relevant to making a decision. If Dr. Grill stands up now and moves toward me, is he threatening me, or is it just ordinary? So that ability to differentiate a threat or make a decision about whether something in the environment is a threat or not could be one of the ways through which people get agitation, by way of example. And in fact, there's one early study, studies always need replication, and hopefully this will happen, that used a brain technique called functional MRI at rest, or resting state fMRI. This looks at what parts of the brain are connected to each other in different clinical states. And each one of the major kinds of behavioral disturbances that we've been talking about seems to have slightly distinct patterns on the fMRI, suggesting that they each have slightly different brain circuits involved in their causation. Again, reinforces the idea that the disease is behind this, not because it damages a specific part so much, but because it interferes with the functions of a brain circuit. And then the third area, which is going to be relevant to some of the therapeutics that we're talking about, has to do with these deep parts of the brain producing chemicals called monoamines, norepinephrine or adrenaline, serotonin, and dopamine. I'm sure you've heard of all of these. There are very local parts of the brain that produce these, and they distribute them throughout the brain. So there's pretty good evidence that they are involved. They're damaged early on in Alzheimer's disease. And it's pretty good evidence that they are involved in the occurrence of behavioral symptoms. And so one of the reasons that drugs that manage, for example, serotonin or manage dopamine, like the antipsychotics, have some value is because they're modulating the damage to these symptoms in a positive way. So let's talk a little bit more about agitation. I think I'm down to my last 10 or 15 minutes, so I'll pick up a little bit. This is the core phenotype. What we mean by agitation is that someone has some form of emotional upheaval. They're labile and changeable. They have psychomotor overactivity. They're moving a lot in different ways or typical ways. They can be verbally or physically aggressive. I'll skip over this slide that basically suggests that whereas agitation gets better with antipsychotics, the effects are very small. And I'll simply make the point that I made earlier that there has been good biologic rationale to study serotonin drugs, SSRIs, quote, antidepressants, for agitation, whereas we know that they don't seem to work specifically for depression in people with Alzheimer's disease. So we did a study a number of years back, which is frequently quoted as a model design and has influenced how studies since that have happened. And this was using citalopram or Celexa as it's commonly marketed, although it's a generic drug, over 9 weeks to treat behavioral symptoms. A couple to treat specifically agitation. A key point to make here is that we gave everybody a psychosocial intervention, and that the psychosocial intervention was deemed to be the minimum what one should do clinically if you have a patient and caregiver dealing with agitation. It was modeled largely after the DICE approach. DICE approach is a way of differentiating and describing behavioral symptoms and coming up with interventions to address them. And what we were fortunate in showing is that, in fact, agitation does get better on both our primary outcomes. But interestingly enough, we focused on the idea of getting people a lot better. So there are a number of people who get a little better, but if you look at the people who get a lot better, On drug, that was about 40%, whereas on placebo, that was about 26%. So the drug advantage, if you will, was that 14% delta, 14% people getting better on drug. What does that suggest? It suggests that if this drug is truly working, it's not working for everybody. It's working for a subgroup of people who are hidden. We don't quite know who they are in this trial. And based on that, we should, in the future, be thinking of how do we find this subgroup so that we can give them the right treatment. Precision medicine is the term that was used earlier. I'll make the quick point that the SSRIs work quite well for delusions and hallucinations in individuals with agitation. Who would have thunk? You can't get delusions and hallucinations better in schizophrenia if you give them an SSRI, but you can get them better if you give a patient with Alzheimer's disease an SSRI, okay? So interestingly tells us that delusions and hallucinations are not all the same, and how they come about in Alzheimer's is different. The subgroup idea we studied in greater detail. We put together a number of baseline characteristics in our folks, created an index, and then everybody had a score, if you will, based on that index. We asked the question, did everybody get better drug versus placebo at each of the 10 levels of that index? And what you see here very briefly is the answer is no. Only about 20% of the people had the right index score whereby the drug seemed to be working. Again, this idea of a subgroup. It's a drug that works, but not for everybody. And how do we move that idea further? Who is the subgroup? So we thought from the clinical understanding of what we have with agitation is that there are folks who are agitated primarily because they're distressed and emotionally labile. They have what we call affective agitation, and you can quantify that. And we also have people who, what we are calling executive agitation. These are people who, if you will, can't help themselves. Something happens, they react. It's not because they're emotionally upset, but because they can't stop themselves, back to the executive idea. And our view was that our drug is working for folks who have affective agitation, but not so much in executive agitation. So in a post hoc analysis, a secondary group analysis, you heard all the warnings this morning, we went back in and we quantified what do we mean by high affective and low executive. And let's look at people in each of these subgroups and can we show that the drug works better. So in the next slide, I'll show you a cross-tabulation. The cross-tabulation will show cells where drug versus placebo was better. And if the hypothesis is downright wrong, you're going to see this red color all over the place, right? If the hypothesis has a little merit to it, then you're going to see the red in one particular area of the cross-tabulation, which is in fact what you see here. So just very quickly to make the point, overall, I told you 40% much better on drug, 26% on placebo. If you look at the blue areas, which are the people high executive, low affective, in that you have null, 29% better, much better on drug, 29% on placebo, 26% on citalopram. So drug's actually a little worse, but not significant. The white areas, again, the same, but look at the red areas, the high affective, low executive people, 14% better on placebo, 52% better on drug. So the idea is that, in fact, there may be the right affective group of folks with agitation who should be getting citalopram. This eventually pulls together in this model that I alluded to. We define things clinically. We're starting to look at the brain, and how the twain shall meet is ultimately where we're headed. And we're in the field studying this for a slightly different drug called escitalopram or Lexapro. The Escitad study, we'd love to have a site in Irvine if you guys would be interested in being part of it. But the idea here is we're starting to develop an algorithm for how we treat agitation, partly based on the phenotype, on the clinical presentation of the agitation, and partly based on understanding its biology. So eventually we hope to have close to 600 folks with agitation. We have about 25 sites throughout the country and several in Canada. And these folks will receive the psychosocial intervention. From the first study, we expect about 25% will get a lot better. That's what we showed before. And then everybody else will be randomized to receive either Lexapro or placebo, and we will evaluate to see if the drug works. We're going to keep following the folks who responded in the first 3 or 4 weeks because we're interested, does agitation relapse, who relapses, et cetera. And what's built into the fabric of the study is this idea of looking for subgroups in systematic ways by combining clinical and a series of biologic, biomarker, and other data. So I wanted you just to kind of get a sense of how the thinking is going, but then to step back and make the point that in addition to citalopram and escitalopram, Celexa and Lexapro, there are a number of really novel mechanism drugs that may be coming onto the market pretty soon, and you see them here. Brexpiprazole is already on the market for schizophrenia. It's an antipsychotic. It's slightly different, might have unique value. Something called deuterated dextromethorphan that many of you, I'm sure, take when you use, or a variant of that when you use cough syrup in the winter. Dronabinol, which is true medical marijuana in the sense that it is an approved way of delivering cannabis in a pill, and prazosin, which is originally a blood pressure drug. So these are examples of where we are with that. Finally, I just wanted you to see this one slide which shows a paper published by a large international group a number of years back making specific recommendations about how you should be doing agitation trials. Who do you enroll? What outcome measures do you look at? What kinds of analyses should you do? And so on and so forth. You don't need to memorize this one, just the figure that I gave you earlier. So let me pull it again together. We've got a big public health problem. We're making progress on the cure side. We all hope that some of these drugs are going to deliver a real cure in the sense that this disease stops in its tracks. It's not looking that way right now. What we have is hopefully going to slow the disease. We don't have evidence so far that I know of a medicine that will stop the disease in its tracks. So we're dealing with a situation where we're going to really change the lives of people, but we're going to convert a 3 to 5 year disease into a 10 to 15-year disease. And managing the behavioral symptoms that, as I pointed out to you, is universal, is continuing to be a major issue. So we have to get ever better at figuring out how to differentiate them, how to use behavioral approaches, how to integrate medicines, and really what to expect overall. And I will leave that there. Thank you. And I have, I think, 5 minutes. There's a clock on here, too. Oh, okay.
We do have time for questions.
Okay.
I see people running to you.
Forgive me if this is already common knowledge, but can you expand on what psychosocial interventions are?
Thank you. I should have. They really have to do with modifying a couple of types. One is modifying how the caregiver interacts with the patient, how they communicate, how they try to get them to do things, et cetera. And the other piece is more on the line of what kinds of activities are done that are specific to the patient. So in the simplest form, that's what psychosocial interventions would be. Other examples would be modifying the environment. It's too loud, too quiet, not enough going on, too hot, too cold, even more basic stuff like that.
Do you have any comments on use of methylphenidate in apathy?
I can't see where you are. Right here. Oh, okay. Do I have comments? Yes. My colleague Paul Rosenberg and a small consortium has been studying the use of methylphenidate in apathy. Their first study called ADMET showed that in about 20% of people you have a very dramatic reduction in apathy with methylphenidate, whereas on placebo you really don't get that dramatic reduction. They're doing another larger trial to confirm. In the folks who did well, there was also some evidence of a cognitive benefit. It's not a surprise that methylphenidate improves cognition. This is Ritalin, for those of you who might not know the chemical name. So the replication trial is really going after two things. One is the idea of there's an apathy subgroup that responds to methylphenidate. Who are they? How can we prove it? And the other idea is how much can methylphenidate improve cognition, and how long does that benefit last?
I think I was not following you very well at the beginning, and my question has to do with you're looking at behavioral modifications, and you showed us some charts, I thought, that said if you are the association between the behavioral abnormalities and dementia. And do you start treating these behavioral abnormalities as though the patient is progressing into dementia before there's a firm diagnosis of dementia?
Yeah, I think I'm understanding your point. Is if someone shows up who's 75 and has a behavior change that fits the MBI, do I know for sure this person will get dementia, and at what point do I start treating them? Right? So the answer to the first one is no. That's the whole point of the research. Some of these people will go on to get dementia. The chart I showed you was if we know you got dementia and we turn back the clock, half of everybody started with behavioral symptoms. In terms of treatments, back to our 75-year-old person who now has MBI, the treatment for me is very pragmatic. It depends on the condition they have now and how disruptive or problematic it is. So if it is clearly impacting on them, their quality of life, and or the family, then we would do something to try and treat it. And there are many options in that setting.
But the treatments would be different if you assumed they were going into dementia versus not.
Well, we don't know that yet. I mean, one of the interesting questions was, what if we used the same treatments at that stage? Would that change the trajectory? Unknown.
One last question to your right.
Yes. When have you studied or et cetera the attitude in which the patients enter dementia or enter MCI? I've experienced some patients who have I will use the word strong spirituality, a strong notion that things are not, when the world starts turning upside down, it is not dealing with their person, but their person is more than their ability to remember or to act. I would think that would begin to change what you talk about as they enter the program, or even as they have intervention in the middle of how you are addressing behavioral issues.
It's a wonderful question that's, if I'm going to translate into the language I might use in research as it speaks to coping style, how do people cope with adversity, and to what extent is spirituality involved, right? And you can study and differentiate different kinds of coping styles. Our group have not looked at patient coping styles in relationship to behavioral outcomes, but we have looked at caregiver coping styles. And caregiver coping styles that are problem-solving oriented as opposed to criticism or punishment oriented are much more effective in how someone with Alzheimer's does over many years. So clearly, spirituality, I'm sure, from my clinical experience, really matters. It definitely matters to the caregivers because they're better able to cope with the situation and more effective with the patient. The extent to which it helps the patients, I don't know.
Thank you very much.